So let us discuss how to approach a hand radiograph in a viva exam. Okay, this is a radiograph of both hands showing bilateral multiple erosive changes. In the right hand, the erosion mostly seen in the proximal interpharyngeal joint, in the interpharyngeal joint of the thumb, in the metacarpopharyngeal joint of the second and the third fingers, in the carpometacarpal joints of the first and the fifth fingers, and within the carpal bones. In the left hand, the erosion seen in the distal interpharyngeal joint of the little finger, in the metacarpopharyngeal joint of the fifth and the second fingers, in the carpometacarpal joint of the fifth and the first fingers, and within the carpal bones. Now let us zoom on one of those erosion and describe it in detail. Let us choose this right hand. We see that the erosions are marginal, juxta-articular in distribution, with well-defined sclerotic edges, some of them showing an overhanging edge, giving a bunched out appearance. We notice that despite the extensive erosions, the joint spaces are preserved. Either it's lost in some of those joints. There is also multiple periarticular dense soft tissue swelling around the proximal interpharyngeal joints of both hands, around the metacarpopharyngeal joints, around the interpharyngeal joint of the thumb bilaterally, and we can see them near the styloid process of both hands. The bone density appear normal. There is no soft tissue calcifications, and there is no fractures seen. So in conclusions, there is bilateral multiple juxta-articular erosion with surrounding dense soft tissue swelling. My primary diagnosis is gout, and the soft tissue masses represent gouty tophi. The differential diagnosis for polyarticular erosive changes of the hand include rheumatoid arthritis, psoriasis, and erosive osteoarthritis. For management, I would like to review the patient's medical history, looking for any risk factor for gout, like chronic renal disease, hemolytic disease, myeloproliferative disorders, hyperparathyroidism, diabetes, and obesity. I would like to compare with the previous hand radiograph to assess progression of the disease, and I would like to review any available radiograph, mainly for the feet, elbows, and pelvis, as are a common site affected by gout. Dual energy CT is helpful in atypical cases, as it can differentiate between urate, mineralization in gout, and calcifications. Also, joint aspiration can be advised for polarizing light microscopy, in which typically show negative birefringent crystals in case of gout. Here the presentation is finished. Just I would like to clarify some simple differentiating points between other differential diagnoses. Let us start with rheumatoid arthritis. First, in rheumatoid arthritis, the distribution of the erosions are mainly proximal joints and sparing the distal joints. The erosion itself are marginal with no subchondral sclerosis or osteophytes or new bone proliferations. Also, we can notice that the joint spaces are usually early lost despite the small erosions, and there is prominent periarticular osteopenia. Next differential diagnosis is psoriasis. Again, the distribution of psoriasis is distal joints with sparing proximal joints. The erosion itself is central in location, and its margin will be fuzzy or described as fluffy margin, not like the erosion in gout, which is juxta-articular and have well-defined sclerotic margin. And also we can see soft tissue thickening around the erosions, which giving the appearance of sausage finger. The other differential diagnosis is erosive osteoarthritis. Again, it's usually involve the distal joints, preserving the proximal joints. The erosion is central with other osteoarthritic changes like subchondral sclerosis, osteophytes, and gouts. Finally, we can note that the bone density preserved in osteoarthritis. I hope those most relevant differential diagnosis, and I hope this will be helpful. Thank you for watching.